Thanks, Marlise. Welcome, everyone. My conflicts of interest. So just a couple of very quick notes. We all know that spontaneous breathing and positive pressure breathing are very different from the physiological point of view. And the title of my presentation is Respiratory Effort during Non-Invasive Respiratory Support. And I will mostly talk about spontaneous breathing because during non-invasive respiratory support, as you all know, the patient is spontaneously breathing. And the issue and also the topic of this congress, of this forum, is heart and lung interaction. And especially when we talk about spontaneous breathing, we need to take into account that the heart and the lung are very close. So the heart is a pressure chamber within another pressure chamber, which is the lung, which is the chest wall and the lungs. And so we always have to remember that there is a strict relationship between what we do with the ventilator on hemodynamics and that the concept of transmural pressure that yesterday Shadow Magda explained very well. We always have to remember that the pressure that distends a hollow structure is the difference in pressure between the inside and the outside of the structure. And so for the heart chambers, the pressure outside is pericardial or pleural or intrathoracic pressure. So we have to talk about non-invasive respiratory support. Why do we want to manage acute hypoxemic respiratory failure with non-invasive support? Well, of course, to improve gas exchange, because we want to support the respiratory muscles and to reduce the work of breathing. And the goal of non-invasive management is to avoid, whenever possible, endotracheal intubation and the complication of invasive mechanical ventilation. And of course, also to avoid ventilation-induced lung injury, because we now recognize that what we were thought to be associated only with the invasive ventilation, so ventilator-induced lung injury, can now also be elicited by our own respiratory effort. Clearly, maintaining spontaneous breathing has a number of advantages on hemodynamics because there is a decrease in intrathoracic pressure because of more homogeneous distribution of the ventilation and better VQ matching. Because of course, if you are spontaneously breathing, you maintain more or less the physiological variability of tidal volume. You use your respiratory muscles, you prevent atrophy, and of course you need less sedation. So there are a number of advantages of maintaining spontaneous breathing in acutely hypoxemic patients, and particular advantages if you can manage them non-invasively. But there are also disadvantages. In particular, the first point I have to stress, which is that usually patients with hypoxemia have a high respiratory drive. And usually high respiratory drive translates in important inspiratory efforts. And this leads, as we will see now, to the development of excessive transpulmonary pressure swings, and so to what we call ventilation-induced lung injury, or for spontaneously breathing patients, self-inflicted lung injury. I want to show this paper that this study that we conducted together with Giacomo Bellani. We took patients on controlled mechanical ventilation and pressure support. Okay, these were intubated patients, but the same reasoning applies also to non-intubated patients. And as expected, if a spontaneous breath or a mandatory breath have the same flow and volume, the transpulmonary pressure change must be the same. What changes is that during positive pressure ventilation, especially if it's controlled positive pressure ventilation, the airway pressure is always above the PEEP level. While during spontaneous breathing, even if it's pressure support, even if you deliver a high level of pressure support, the pressure can be negative and can be if the patient has a high drive and makes high inspiratory effort, alveolar pressure can be truly negative. And this is very important and has very important hemodynamic consequences. So this is an example. You can see in the upper part of the slide a patient on controlled ventilation, in the lower part a patient on pressure support ventilation, and if you calculate transpulmonary pressure, which is the pressure that distends the lung during static condition, it's the same. In this case, 40 centimeters of water. But what we can see is that during pressure support ventilation, since this patient was breathing against a high resistance, he was doing huge effort, and alveolar pressure is very negative, like -20. So same transpulmonary pressure, but very negative value of alveolar pressure. And also, we have to remember that the ARDS lung is highly homogeneous, and stress and strain do not distribute equally, homogeneously to the lung parenchyma. And then during spontaneous breathing, there is this phenomenon of Pendeluft that for some areas increases the level of stress and the effort and the negative pressure swings. So negative values of alveolar pressure have consequences on the fluid shift. And this was taught us by Starling, that proposed the Starling law that describes how the fluid moves across the vessels. And you know that there is a pressure difference between the intracapillary pressure and the interstitial pressure, and then there is the oncotic pressure in play. And when we have really negative alveolar pressure, we have negative interstitial pressure. So there is a force that forces the fluid outside the vessels in the interstitium and leads to pulmonary edema. And as you can see here, in conditions of low extravascular pressure and of high permeability, like in ARDS, the amount of lung water for the same pulmonary artery occlusion pressure is much higher than in normal conditions. So in the end, high inspiratory effort translates into high transvascular pressure that push the fluid from the capillary to the interstitium, leading to pulmonary edema. One clinical example of this is negative pressure pulmonary edema. You know, it's pulmonary edema that generates when you do very high effort against the occluded airway. And the mechanisms are not completely elucidated, but the most probable is fluid shift due to negative intrathoracic pressure, as I showed you. Also, there is clearly in hyperadrenergic state because the patient is feeling that he's choking, and the peripheral vasoconstriction increases venous return. And also, very important, negative intrathoracic pressure increases left ventricular afterload, which is the reason why in patients with cardiogenic pulmonary edema we apply positive pressure, because PEEP in patients with cardiogenic pulmonary edema, in patients with failing left ventricle, decreases left ventricular afterload. So high inspiratory effort, negative effort, increase left ventricular afterload. So in this situation, we have increased fluid shift, we have increased venous return, we have increased left ventricle afterload, and all this leads to pulmonary edema. Another clinical example of the negative hemodynamic consequences of high, huge inspiratory effort is weaning failure. And this has been shown very clearly by François Lemaire in this paper published in Anesthesiology. You can see there the level of pulmonary artery occlusion pressure and the swings in esophageal pressure during a weaning failure during a winning trial that failed, and there is also clearly the issue of ventricular interdependence with the enlargement of right ventricle that compresses the left ventricle. So in the end, all this results in the vicious circles of patient self-inflicted lung injury. What is very important, and this is the last part of my presentation, is that if you want to assist a patient with acute hypoxemic respiratory failure with non-invasive ventilation, with any form of non-invasive support, or even if he's intubated, you want to keep him in pressure support, so you want to keep some level of spontaneous breathing, you have to monitor the patient. This is the most important thing. And if we talk about non-invasive assisted patients, okay, there is not only PF ratio. During COVID, we've been talking a lot about PF ratio, but we know that PF ratio changes a lot with FiO2, it changes a lot with the level of interpulmonary shunt, and we know that some patients can tolerate very well even severe hypoxemia. So we need to monitor the patient. Very simple things like respiratory rate, it's a very important part. Use of accessory muscles, dyspnea, PCO2, because if you have an hypoxemic patient who is also hypocapnic, this means that that patient must have a high respiratory drive. Tidal volume, we now have some instruments to monitor tidal volume even in non-intubated patients, even on CPAP or on high flow. Clearly, we need to monitor hemodynamics, but the real target is to monitor the patient drive and effort, because as we have seen, if the acute respiratory failure is associated with increased drive and huge inspiratory effort, there might be very negative consequences at the pulmonary and hemodynamic level. So how do we monitor drive and effort? Well, for the effort, the golden standard is, of course, esophageal pressure. There are studies showing that you can that the level of esophageal pressure swings predict the rate of failure of non-invasive ventilation. It's been applied by some groups during COVID-19. We all know that it would be very nice to have to monitor continuously the esophageal pressure swings in spontaneous breathing patients. This is not always easily feasible, especially outside the ICU. I just want to show you that there are less invasive ways that can be used to monitor the effort of the patient. One is the swings in nasal pressure. Now we have only experimental data, but where this group is trying to now to go into more extensive groups of patients. But it seems that the swings in nasal pressure during inspiration reflect quite well the swings in esophageal pressure, and also the swings in the CVP line. So if your patient has a CVP, has a central venous catheter and a CVP line monitored, if you see deep decreases, these inspiratory decreases in the CVP, this means that that patient is doing huge inspiratory effort, has huge inspiratory swings of intrathoracic pressure. So this is non-invasive, you can do it at the bedside. There is also the monitoring of electrical activity of the diaphragm, which is another proxy of the drive and of the effort of the patient. I know it's not very popular and it's not so diffuse. I just want to show you that there is also a less invasive way to monitor the activity of the diaphragm and of the respiratory accessory muscles, which is surface EMG. We are now using it, and apparently the swings, the level of diaphragm activity is corresponds quite well to what we measure with the EDI catheter. And what is important with this technique is that we can also monitor the activity of the accessory muscles, inspiratory and expiratory muscles, so you can also monitor how much the patient is pushing with the expiratory muscles. So in conclusion, I think that we all know that spontaneous breathing is good, at least for some patients, but we must be aware of the potentially negative consequences of it, and we need to strictly monitor the patients, especially the drive and the effort of the patient. Thanks.
Thank you very much. There is room for some questions from the audience, so identify yourself and speak up. Okay, thank you.
Thank you, Giacomo. That was really good. It really helped me for my talk coming up later, frankly. But my question for you, because I struggle with this at the bedside. So you have a patient who's spontaneously breathing pressure support, very negative pleural pressures. You're measuring it with an esophageal balloon. Tidal volumes are 10 mLs per kilo as they pull in. Do you sedate them? Their oxygenation is okay. Their PCO2 is okay. If you sedate them, you know those are all going to go off. Or do you let them do it? I know the theory. What do you do in practice?
Well, in practice, if I see huge swings in esophageal pressure and large tidal volume, even if the blood gas is okay, we tend to go back to more controlled ventilation.
Giacomo, thank you. Massimo Antonelli, Rome. Thank you very much for your presentation that illustrates all the risks. But I guess that we need to be careful, because we may run the risk of criminalize the spontaneous breathing, which is wrong. I guess that, as Magdalene Schell said, we need to be practiced at the bedside. Mm-hmm. And it is obvious that it's not so common having the EDI, having the electrical impedance tomography or whatever. So, if the patient is spontaneously breathing on non-invasive ventilation, the only things they can do, looking at the publication from Guillaume Cartot, is the entity of the tidal volume.
Tidal volume, yes.
This is the only things that we can do. And look at that. But we need to be aware that the response to the pressure support may be different depending upon the condition of the patients. At times, the inspiratory swing is deeper, at times it's reduced. And then it is obvious that the transpulmonary pressure change. So we need to evaluate carefully, case by case. This is my personal message.
I agree. And I'm not a Taliban of tidal volume. I mean, I invite you. There is a very nice piece written by Robert Bartlett. It's two pages. It's called "The Old Man and the ICU." If you want to read it, it's very insightful. I'm just saying that I agree with you. We know that non-invasive support can be beneficial. We know that the patient can make it with non-invasive support, has a much better prognosis than if they need to be intubated. And the question by Sheldon was, if we have the monitoring of the esophageal pressure, you cannot ignore like -20, -25 of esophageal pressure swings at every breath. If you don't have it and you see that the patient is comfortable, you don't see the use of accessory muscles, PCO2 is not 20, then you can try to maybe adjust a little bit sedation and do that, but again, always under strict monitoring of the patient condition, because we also know that if we delay intubation, then the prognosis will be worse. So it's a difficult balance, I understand.